right, so we're going to talk about psychotropic medicines now, and I will make the caveat that I don't prescribe these very rarely, if at all. Sometimes I refill them, but my practice is I do a lot of fill-in work, and I feel that these are appropriately prescribed by a primary care provider or a psych mental health person. But I do know a lot about medications, and I can talk to you about sort of the general issues around prescribing these. And even if you're not prescribing them, you need to understand them, because you may be the person that's monitoring the adverse effects or making sure that the person who's getting them is getting the treatment that they need, because there is some monitoring that needs to happen with some of these. I am going to talk about some off-label prescribing in this around antidepressants and atypicals, but they are guideline-based off-label prescribing. So this is a little different. We're going to do a little bit more pharmacology. We're going to talk about sort of the basic mechanism of action of some of these drugs. We're going to talk about the pharmacogenetic influences, and talk about sort of issues around managing and co-managing children and adolescents on antidepressants and atypical antipsychotics, because they seem to be prescribed quite a bit. So let's talk about trends in prescribing. This is from a couple years ago. Foster children, when they looked at foster children with mental health diagnosis, they followed them for 3 to 4 years, 19% of them were on 3 classes of psychotropic medications. Stimulants, 69% of the kids were on stimulants. 65 were on atypical antipsychotics. And so these are concerning because that's a lot of kids on those. But you know, the fact that they are on not just 1, but they're on 3 is a little nerve-wracking to me as when I look back and go, wow, why do we got all these kids on all these medicines? And we looked at another Medicaid. The reason we can do Medicaid prescribing information is because they keep a good database, right? It's a little harder to do it in the private when people are going to Walgreens one time and Costco the next time, and you know, it's hard to figure it out, whereas you can look at sort of payer information this way. So one of the things that they found is between 2000, 2004, and 2008 that there's an increase in second-generation antipsychotics that are being prescribed. So that's your sort of your Risperdal, some of those others, and that 85% of these kids were on another psychotropic. So we're not just talking about one medication, we're talking about multiple medications again. And the highest users were kids in foster care and disability Medicaid. So this is actually a nationwide concern. This is Greg Kearns in Kansas, great guy. I love to go to meetings with him. He's just really fun. But they look at psychopolypharmacy. This is really kind of scary, what is happening, and the amount of psychotropics that are being prescribed to kids. They did a national survey of child psychiatrists. By the time they're getting to the psychiatrist, they often have multiple psychiatric or behavioral diagnoses. Most of them are prescribing multiple medications. And interestingly, though, child psychiatrists were the most likely to prescribe on-label and least likely to prescribe completely off-label. So that means somebody is prescribing off-label for these kids. And one of the things that they called was partial label. So it's correct for the diagnosis, but not the age. So a lot of these drugs are not approved down to the younger ages, but we're giving them to these younger ages. So just sort of keep that in the background. Psychopolypharmacy is the new term for this. Not new, but anyway. We're going to start with depression, and we're going to talk about evaluating for mental health disorders. How many are familiar with the GLAD guidelines, GLAD PC? Good. If you've heard my talks before, I try to get people to get into them. They look at it's the guidelines for adolescent depression in primary care. So it's really specific to people who work in primary care. It's for people. It kind of walks you through. It's an excellent document. It's a huge resource tool. They call it the toolkit, and really basically that we should be identifying these kids in primary care, and we should be monitoring them over time. And so how many of you are screening all your adolescents for depression? Good job. Good job. It's now standard as part of our adolescent questionnaire that we give to all of our teenagers where I practice. And the other thing is you can be sure to bill for it, okay, that you're screening, because somebody at some, like CDC or something, is going to go into the nationwide database and want to know how many adolescents are screened for depression. If you don't put it as a code, as a diagnostic code, then it wasn't done, even if you did it. So be sure to put it in as a diagnostic code. Primary care clinician should evaluate depression in high-risk adolescents as well as those who present with emotional problems as the chief complaint. And really what we should do is screen everybody and then evaluate more in depth. So there is a large consortium. If you've ever been to the National Institute of Mental Health website, they've got some amazing stuff happening there. And there is a consortium it's the Psychiatric Genomics Consortium. It's 300 scientists at 80 research centers in 20 countries. And it is, what they're looking for is sort of to try to figure out the genetics behind mental health disorders. It's a huge genome study. They looked at the 5 major illnesses and looked at the genetic variations for these. And so we've, if we look at schizophrenia, there's 23% of schizophrenia is accounted for by genetics. But if you look at twin studies and family studies, it's 81%. If you're looking at bipolar disorder, it's 25%, ADHD, 28%, 14% autism, and 21% depression. So there is a cluster of these disorders that appear in young adulthood that seem to have the same gene pathway and an overlap between the heritability attributes. And that's schizophrenia there's a 15% overlap between schizophrenia and bipolar, and a 10% overlap between bipolar and depression, and a 9% overlap between, oh gosh, my thing doesn't want to scroll down. Sorry, I'm going to get my paper notes because I have this on a note, because I just want to, it's really important as we're looking, because you need to get a good family history with these kids. So a 9% between schizophrenia and depression, and 3% between schizophrenia and autism. So there's clearly genes involved here, and there seems to be this clustering of schizophrenia, bipolar, and depression that kind of go together. This was just a 2015 publication where they looked at this, and I think that this is an area where we're going to see a lot more information. So basically, this is how it sort of ranks out. And so what they did was, this is just the single disorder heritabilities, okay? ADHD, remember we talked about that, 28%. Bipolar disorder, schizophrenia, major depression, autism spectrum. Then they looked at the genetic link between the things that are co-inherited: schizophrenia, bipolar disease, major depression, schizophrenia, major depression, etc. So what we're seeing is that among pairs of disorders, schizophrenia and bipolar share about 16% of the same common genetic variation. So it's not as random as we used to think. We kind of always thought that kind of this ran in families. This is more and more we're learning. This is straight genes. They didn't look at any people. They just look at genetic stuff. They look at genes. So now what we have to do is take this and bring it to the people and see how this all plays out. But be sure to do a good family history, because if you've got any of these disorders running in a family, you're greater likelihood to see it in your patients. And why do I want to talk about genes? Well, remember we talked about pharmacogenomics and pharmacogenetics? Well, if you've got a gene-related disorder and you've got a medication that has some genetic variation, you've got more complexity than normal. You've got two things you're dealing with, and so you always have to be on top of what's happening in the research, because there may be some depressed people who don't respond to some antidepressants because of genetics, okay? So it gets complex. But the more we know, the more we'll be able to identify, okay, and be able to say, oh, these people with this genetic polymorphism with depression shouldn't be started on this medication because they're not going to respond. So that's where we're going to get to eventually, once all this kind of gets sorted out. All right, so let's just talk a little bit about depressive disorders. At any one time, 4 to 6% of adolescents have a diagnosis of major depression. Now, if you look at adolescents in general and you ask them if they ever have depressive symptoms, you're getting up to 50% of them. Because if you work with adolescents, you know, they kind of do this just normally, right? They have some days it's the worst day in the world and whatever. But to really look at the sort of long term, it has to be over time and it has to be sustainable. Who is really depressed, major depression, it's about 4 to 6% of adolescents. So remember, there's differing levels of depression, and so you can have mild depression, you have major depression, and we're supposed to use medication for major depression. The medications work in the chemical pathways of the brain, which we think is the problem. Be sure to rule out any sort of medical disorders. Always screen for hypothyroidism, because hypothyroidism will mimic depression, and hyperthyroidism will mimic ADHD. So always be checking their thyroids before you're diagnosed or before you're prescribing any psychotropics. And be sure to screen for bipolar disorder, because if you understand how these medications work, if you have someone who's bipolar and you put them on an antidepressant, you may then put them into a manic state, because you're going to increase the number of neurotransmitters in that synapse. So be sure to screen for bipolar disorder. And the big way to screen too, not only their symptoms, but family history, okay? And if you're not sure, then instead of putting them on antidepressants, maybe they need to be seen by somebody who's a specialist in this area. So symptoms of major depressive disorder, you need to have persistent and pervasive depression, irritability, loss of interest, loss of pleasure in almost all activities. They can also have disruptions of sleep or eating patterns, energy, inability to concentrate, feelings of worthlessness, etc. You all are familiar with this if you're working with these kids. The thing to know too is that even if they're treated, 40% are going to have a recurrence in 2 years, and 70% will have a recurrence in 5 years. So we need to get their treatment, but we also need to be on top of them, because they can have a lifelong problem. So one of the issues around depression, especially in our adolescents, is you've got multiple things going on. You've got sort of the physiology. We know that there is a neurotransmitter issue. There's not, there's something going on with norepinephrine, dopamine, and serotonin. The reason we know that is they respond to medications that increase those, okay? So there's something, probably most likely serotonin, but we see people with depression that respond to the other drugs too. So we know that. Do we know why? Not 100%. There's probably some genetics. Do we know 100% of all of what causes depression? No. We definitely know part of it is this brain chemistry piece. The other thing that we see is when kids go through puberty, when you take the hormones that are increased during puberty, they actually increase depression symptoms. And so we've got, especially with our adolescents, you have an increased risk during that time. Inadequate sleep. So one of the things too, especially if you work with these kids, is we need to do some lifestyle issues, even if we give them medicine. And not getting enough sleep, actually, you can take somebody that's sort of coping okay, and now we sort of drain them by not getting enough sleep or prolonged stress, and that seems to kick people over into more depression symptoms. Is it like depleting all those neurotransmitters? We don't know 100%. We can't go in there and test all that. But we do know there's definitely an association with inadequate sleep and significant stress and depression symptoms. So it's multifactorial, so the treatment needs to be multifactorial. Medications alone in adolescents is not the answer, okay? And that every study says that. It's only a piece of the answer because it's only a piece of the problem. So if you are working with adolescents, you need to diagnose the depression appropriately with a evidence-based tool. There are a number of tools. There's the Children's Global Assessment Scale. Most people, are you guys using PHQ-9? That's what we're using? Yeah. And it's modified for teenagers, and it's a great tool. It's really easy to give in the clinic. We actually have a couple screening questions that sort of asked that in the last 2 weeks. You know, have you felt sad or something? And then that's an all, for all kids get that. And then if they score above a certain point, then they get the full PHQ-9. And then we score them on that so that we're picking up all these kids. So don't think you need to memorize all of this. This is actually in the GLAD PC toolkit, but this was published in Pediatrics in 2007, and it was reiterated and updated in 2010, and nothing since, because I think that's a pretty solid guideline, and this is what people are doing. I'm going to blow it up just a little bit. This is the assessment piece. You need to assess them with a systematic depression scale, and then determine where they score on that. And then what you need to do is look for comorbidities, determine whether there's suicide risk, and go from there. And so if you've got these kids that are suicide risk, that's really easy. You send them to an emergency suicide treatment program. If you have to look at where the family is, so if they're not at high risk but you're concerned, you got to find out, can the family check on them? Do you have a safety plan, etc.? And then you develop a plan. And then if they don't score, figure out what else is going on, you know, and send them for evaluation of that, or to continue to evaluate them for depression, okay? Because these kids, remember, they can cycle, and if they get stressed or they don't get enough sleep, they could score higher and actually then score as depressed. All right, so how do we know who's at risk for depression? They call it the sad persons. So females attempt more, males complete more, age over 16, depression, previous attempts, alcohol use, rational thinking loss. So if they're psychotic or taking intoxicated, social support's lacking. If they have an organized plan, no significant other, meaning they don't have any friends. If they're sick or have a first-degree relative who's a completer. So some of these are at higher risk, the organized plan, those people, and if they are lacking a rational thinking. So, you know, always assess for suicide and figure out how high a risk the kid is no matter what you're doing. Okay, so these are the management flow charts. Everybody gets psychoeducation and supportive counseling, okay? We need to have parental and patient self-management. You can refer them to peer support. So it isn't just giving them medicines, and that, I think, is the take-home message. I see, once again, I'm doing a non-pharm, don't prescribe. No, you do prescribe, but you have to do all these other things. And every research they do in adolescents specifically, their outcomes are so much better if you do the counseling. They need that other piece. They need how to retrain their thinking when they're not feeling well and when they're sick or when they're tired. They need to identify, I'm tired, I'm not depressed, I need to, or I'm depressed and my lack of sleep is making it worse, and helping them come up with coping strategies. So if you want to get them referred, you can manage them in primary care. You can initiate therapy with medications. We monitor them closely, but everybody needs to have some sort of beyond just medications, okay? You also, even if you don't give them medications, you still want to monitor them closely and stay in touch with them if you refer them. Because you're still their primary care provider even if they go to mental health. So what we do is you put them on, you can put them on medications. If they're partially improved after 6 to 8 weeks, you could change or increase their medicine. If they're not improved, reassess your diagnosis and considering adding in a second medication. If improved after 6 to 8 weeks, you continue the medication for a year after full resolution of symptoms, okay? And monitor for 6 to 24 months after that. So after they come off, they're not done. They need to keep, but the other thing too is they should, at some point, you should try to get them off of the antidepressants. They're not depressed for life. This is sort of not a lifetime illness in these people, generally. I mean, you do have people that do, but all of a sudden it seems like everybody goes on and nobody ever considers weaning them off and getting them back to sort of managing their life without medication. We are seeing a huge number of college students that are on antidepressants. Okay, so if you're going to start with this SSRI, selective serotonin reuptake inhibitor. The first choice, first line is fluoxetine. That is approved across the ages. And second line are the other ones. First line for 12 and over is yeah. Which one is this? Is this one? I always know my generics. Which one is this? Lexapro? Lexapro? Okay. Okay. And so, and then the other ones. Now, I put that tapering schedule in to remind people that you are supposed to eventually taper people off, okay? But you don't stop these suddenly, because what is happening is you've got all this extra help with these neurotransmitters, and you are providing this artificial support. And so if you suddenly stop that, they're going to immediately be depressed because we've taken away it all. So what you do is you taper them off so they start to make their own and kick back into their own system. It's that negative feedback. If we alter it by medications, the body sometimes just doesn't make enough. So you wean them off slowly. If you're going to move them, 1 to 2 weeks for every 10 milligrams. You're going to go really, really slow. It may take you a couple months. If they start to have symptoms, you put them back up and go even slower than that. So be sure you are thinking about weaning and have a plan. So when you prescribe it and you monitor that, once you get them stable and say, okay, we're going to see you every few months, but a year from now, we're going to review this and we're going to start thinking about getting you off because you don't need this the rest of your life. Most people don't, okay? So just think about that. These are what the SSRIs do, okay? What they do is basically what they think is somewhere there's not enough of these neurotransmitters. They're norepinephrine, dopamine, and serotonin. And the SSRIs are selective to serotonin. They're selective serotonin reuptake inhibitors. So what they do is they block the reuptake on the presynapse so that so basically the neurotransmitters are produced, they come down in the synapse, they attach to these postsynaptic receptors, right? Depression says somewhere along the line there's not enough. So, and then the other thing that happens is they reuptake, they go up into here, they recycle, come back down, and cycle back through. So by blocking the reuptake, the net amount of serotonin that you have available to attach to these receptors increases. It's straight pharmacology and chemical brain chemistry. It also tells us why they have a lot of ADRs, because you have all these problems with all this excess in this synapse. All of them work very similar. The tricyclics do the same thing, except they're not selective to serotonin. They also, so you end up with both the norepinephrine in here, which is why you have a lot of cardiac side effects. Remember, this SSRIs are supposed to be used for major depression. It's not just the blues. It's not just if they're not feeling good. I worked with a pediatrician who literally kept a box of Prozac on her file cabinet. If kids came in, they weren't feeling well, they got some Prozac. And I'm thinking, oh my gosh, this is horrible. That was before we had a black box warning. The best thing about the black box warning is now people actually do a true assessment and they appropriately prescribe these. And I still think they might be overprescribed a bit, but hopefully most people are doing a good, thorough assessment and they're monitoring and prescribing appropriately. So fluoxetine is not only approved for depression, but also for OCD, and it's approved for OCD for 7 to 17-year-olds and 8 to 17-year-olds for major depression. Lexapro is approved in age 12 to 17-year-olds for major depression. So this is where the psychiatrists do. They're giving Lexapro to an 8-year-old. So it's partially off-label, right? It's on-label for depression in kids, but not 8-year-olds. That's where that earlier study was talking about. There's a new combination drug, which is approved in 2013. It is for pediatric patients, 10 to 17, which is a combination of a atypical and Prozac, and this is for treatment-resistant depression. Kids had a lot of problems with that. So what is the deal with these? Well, one of the things that ADRs that we see are adverse drug reactions we see. Fluoxetine, we see some weight gain with that. We see some poor weight gain in young kids. And so you definitely want to monitor these kids, not only their mental health disorder, but also watch their weight and their growth. Some of these others are not approved for kids. Luvox is not approved for depression in pediatric patients. And it is approved for OCD in pediatric patients. So this is one where make sure that you're prescribing the right medication for the diagnosis of what they have. And so, yes, they can be on Luvox or fluvoxamine, but if you have a kid that's depressed, then they probably shouldn't be getting this. And the reason that they did this way is they have done the studies, and these drugs are not as effective in depression in kids as they are in adults. And so, yes, OCD and depression are two different diseases. And so you can take a medication that, yes, is approved for one disorder in kids because it works, and it's not approved for another disorder in kids because it doesn't work. And they've done this because they've done the studies. That's why these drugs are labeled this way. This was part of the Best Pharmaceuticals for Children Act. They really drilled down on all these different psychotropics in kids to see which ones work and which ones didn't. So that's why they're not approved for depression in kids. Zoloft is the same. The ones that are not approved for kids, Effexor, Paxil, Celexa, and Cymbalta. The one that has the ad on TV. Effexor, what they found is that, let me see. They had problems with growth. They had problems with height. They didn't grow as both weight gain and height with Effexor. So there were some adverse effects from these, as well as not being as effective in kids. Bupropion or Wellbutrin is not approved for pediatric patients. Are you guys still seeing people using this off-label for ADHD? Yeah. So this this doesn't work against serotonin. It works against norepinephrine and dopamine to prevent the reuptake of those. And so they keep saying research is ongoing or more research needs to be done. I keep waiting to see a study that says it works in kids. But we've been talking about bupropion use in kids for almost 12, 13 years, and it's still being prescribed and it's not approved for kids. So what is the issue with the SSRIs that we need to watch for, besides treating their depression? One of the things that we have is slowed growth velocity, that they, especially with Prozac or fluoxetine, they're weighing less, which probably isn't bad because we got a lot of overweight kids. It's only 1 kilo. But they're also going slower in their height gain. And so we do want to monitor those kids pretty carefully with height and weight. In younger kids, there's a lot of behavioral disinhibition. So then what do we do? Then we diagnose them with ADHD. Right? So we give them one medicine that causes behavioral disinhibition. Oh, guess what? Now they have ADHD. But it's probably, we need to think about, is it the medication that's causing that? Or do they really have ADHD or not? So what I see happening is people just keep layering on the medications. It's sort of like they're on one to treat a symptom, to treat something, and then they have symptoms, so they layer on another one, layer. Next thing you know, you've got these kids on 2 or 3 psychotropics, and we do not have good long-term data on what these kids look like as adults. We don't know what's happening to their brain chemistry. We don't know if this is causing permanent changes. We don't have, because we haven't been doing it long enough. I think we're going to be sitting here 10, 15 years from now going, we kind of messed up a little bit. And I don't know what that's going to look like. I can guess, but I don't know. So we really need to be very careful and thoughtful about this. And everybody's overprescribing. It's not, I mean, everybody is overprescribing. You talk about the elderly, they are way overprescribing for those people. And so, but we all just have to back up and say, what are we targeting? What medication are we giving? We do see a lot of sedation. The suicidality risk is smaller than we thought. It's maybe 1%, and it is increased until age 25. So we do have to pay attention to that black box warning. We can't just ignore it. It probably was one of the best things that happened, because I think before that people were prescribing inappropriately. I think people are better about prescribing and educating people, but we do have a risk, and be sure when you're prescribing them that you're talking to people. The other thing we have to worry about is serotonin syndrome. And one of the issues is that people on SSRIs are out there doing all kinds of things. These kids are taking ecstasy. They're robo-tripping on dextromethorphan. They're doing all these other things. And all of those are making a risk for serotonin syndrome. Plus, someone goes, oh, I hear that St. John's wort works, so they're adding that in. That will cause serotonin syndrome. So serotonin syndrome, if you can't remember that from, it was probably a while ago for some of you when you took pharmacology, is that it's a life-threatening condition. It is basically you have too many neurotransmitters. You get restlessness, diarrhea, hallucinations. You can have seizures. You can have DIC. You can die from it. You need to really quickly be on top of this. So if you're prescribing any antidepressants, you need to educate about serotonin syndrome. These people should not take anything, over-the-counter, herbals, whatever, without either talking to you or the pharmacist to make sure if there's a drug interaction, because there are a lot of drug interactions with these drugs. Triptans for migraines. I mean, you can go on and on and on, the things that these interact with, and so many of them, they're available over the counter, especially the herbal products. So, oh, I already had that slide. I don't know why I changed it. Here we go. Okay, so the other things we need to look at is the therapies, what works. There's cognitive behavioral therapy, and there is, what's the other one called? Interpersonal therapy. And so basically they look at cognitive behavioral therapy looks at influencing their behaviors and feelings, and thinking about how does their thoughts influence their feelings. And interpersonal therapy is really about how to work on interpersonal problems. There are multiple studies that say that a combination of therapy and SSRIs have the best results. I've only listed a couple, but actually we did a big one at Kaiser. We enrolled all of our kids that started on antidepressants. We asked them to go into this to treatment, and we definitely better outcomes, better management of their depression, not have to go on multiple medications, better outcomes, being able to wean off their medication, etc. So always, and I know that the mental health resources are low. I know that there's not enough people out there. I know that the coverage for mental health care is not good, right? But that doesn't mean that we can abdicate our, just think that a pill is going to fix it, because the best outcome is to figure out, so whether you're working with the schools or whether you're working with the local mental health society, you've got to figure this out. The ACA is supposed to be covering this as it gets rolling. I would hope that, I mean, but it's still not great. And ours, or even at Kaiser, okay, so everybody gets mental health coverage except if they're Medicaid, and those people, it's not covered on the Oregon Health Plan. They have to go someplace else to get, it's sort of like, and so they're outside of Kaiser, so then we have to figure out what did they prescribe for them and get it all back, and it's like, it's very chaotic, and that's unusual for us because usually we're kind of a closed system, except for mental health for Medicaid patients. So anyway, it's a mess, and we've got to make it better. But just prescribing without the other pieces is not going to make it better. So co-management. So these are the people that you want to think about. Are they seeing other people, making sure that whoever is prescribing is also doing the other pieces. They've ruled out bipolar, monitoring them for symptoms. So I get a kid who comes into urgent care, right? And they've got all these symptoms, and I'm trying to like, what is going on? And I finally figured out it was adverse effects from, they were dizzy and they were having these problems. They had been started on a SSRI by somebody else and came to see me for their dizziness. So we need to think about, taking that history. How long have they been on? You're supposed to taper them up, especially adolescents. They don't do well if you start them on a high dose. You want to go really slow. So think about that. Are they doing the lifestyle modification? And even if you're not the prescriber, if you are prescribing, you need to make sure that what you're prescribing isn't going to interact with that SSRI. So make sure that you're looking up everything and double checking all of your drug interactions. So what we do is we put them on 6 to 12 months after their symptoms stop, so cessation of symptoms. They may need 2 or more years of therapy. Once they're stable, we follow them up. And then what we do is we want to eventually wean them off and go very, very slowly and get them tapered off their medicine. So you don't just give them a prescription and say, okay, I'll see you next year at your well child visit. All right, you gotta be on top of them every 3 months. You need to check on them. You can do it by phone, you can do it by email, but you do need to make sure that once they're stable, that you're watching them every 3 months. Eventually, we'll be able to do more and more electronically. They just get a survey, how are you doing, and it kicks in. But I don't think that is good enough. I think if we are the prescriber, we need to really make sure they're following up. And if we're not the prescriber, make sure they're following up all the time. I see people. It doesn't even matter, whatever specialty it is. Well, you haven't been back to see the neurologist, or you haven't been back. When was the last time you went and saw your psychiatrist? I'm not going to refill your medicine if you haven't been going to your therapy. You need to make sure that they are actually going back and following up the way they're supposed to. Because they will come to you and say, oh, I need a refill. Do you see that? How many people see that? Yeah, it's pretty common, right? So just refilling is not all of it. I won't say no, won't refill for you because you don't want them to have withdrawal symptoms, right? Because that'd be really bad. But you say, I'll give you a little bit of a refill, but in the meantime, you need to get an appointment before this runs out because I'm not going to refill again unless you see your psychiatrist. So really make sure they're doing what they're supposed to be doing. This GLAD PC toolkit is amazing. How many of you guys have seen it? Okay. If you haven't, it's like gladpc.org. It's really easy. And it is the most complete resource all in one place. It's a PDF you can print off. It's got all the depression scale tools. It walks you through prescribing all the different antidepressants. It talks about the different types of therapies. It is very complete. It is what the AAP recommends for us to use. I know that NAPNAP also has a tool, but this is, if you want to really be out there and looking at things, this is great. It also has screening tools in English and Spanish. So if you're looking for Spanish materials, it's in here. So then we have the atypical antipsychotics. These are a little bit more complex, and we don't know 100% what they do, which just makes them more complex. For kids, they're used for Tourette's syndrome. They're used for autistic disorder appropriately. On label, they're labeled for autism, childhood schizophrenia, and bipolar disorder. So some of them, you're going to definitely see these kids with taking these. We think that it's a agonist antagonist, meaning that it works to increase the neuroreceptors on some and block others. So if you think about schizophrenia, it's probably too much dopamine, all right? And you got to block those receptors. And then you've got bipolar disorder, so you don't have enough. So it's it's this mixture of what it does, which is part of why you have some of the adverse effects that you have. And we don't know 100% exactly what these do, which is kind of scary. So this is our brain, okay? And our brain on chemicals. So dopamine is one of our neurotransmitters, comes down and attaches a dopamine receptor. We think that schizophrenia is, we got too much dopamine, all right? Too much dopamine and you get manic. And you know how to make someone manic? Give them some amphetamines. Because you know what amphetamines do? You get too many neurotransmitters. Okay, you give somebody a whole bunch of amphetamines, you do this. You're going to get someone manic. So they think that's part of the schizophrenia, too much dopamine. So the drugs, especially the older ones, block the dopamine receptors. So all this extra dopamine can't go to the receptors. It doesn't mean they stop making the dopamine. It just can't do anything. So that's great, except for when you think of Parkinson's disease where you don't have enough dopamine. So that's why these people, when they take these antipsychotics, we are basically creating Parkinson's because now we can't do that. So that's why they have that adverse effect. So we always have to think about what we're trying to treat and then what problems are we creating when we give them the treatment, all right? So these are the typicals. The atypicals work slightly different, but this is sort of your typical antipsychotics. These are the approved age ranges for the atypical antipsychotics. So we have, for autism, is the gold bar, all right? Risperidone, 6 to 16 or 17, all right? And here we go, ariprazole. I'm terrible at my Latin names here. This one. So, and then we have bipolar disorder, schizophrenia. So Risperidone is the reason that we see lots of kids on it because it's the one that's got the most age range here. We have to consider the fact that schizophrenia doesn't show up till later, which is why it's approved later. We definitely don't see kids diagnosed with schizophrenia younger. Bipolar disorder, we're starting to see more and more kids diagnosed younger as we figure out this disease. Anyway, what they say is that you should be giving Risperidone to anybody over age 16 for autism. Okay? And this is from the Centers for Medicare and Medicaid Services. So remember how those studies about all these kids on Medicaid are getting all these atypicals and all these multiple drugs? They're tracking this and they're really watching this closely. They had a big document that they printed in 2013 and they are really trying to get people to prescribe these appropriately. So Risperidone is for schizophrenia in adults and adolescents, short-term treatment of bipolar disorder, autism disorder, and one of the things is that there's a post-marketing study. So all drugs now get a post-marketing study 18 months after they come on the market. Because how many drugs in your career have you seen come on the market a year or two later they were taking them off? Because there's been some bad thing. That's because all drugs now get post-marketing surveillance, and it really kicks in at 18 months. So what we're finding is that they have some irritability that was found in the autism patients on post-marketing surveillance of Risperidone. Abilify is also can be used for the younger kids in autism, and then of course older kids with schizophrenia and bipolar. Seroquel and Zyprexa are only for adolescents for schizophrenia and bipolar disorder. It's not approved for autism. So one of the issues that we have with these atypicals is that these drugs we don't have good long-term data in kids. We don't know 100% what they do to brain chemistry. We know a little bit. But when we look at kids, they tend to have more adverse effects than adults. And they have more sedation, and both in the clinical trials and the post-marketing reports. They have extrapyramidal symptoms, which makes sense because we've blocked those dopamine receptors. They have drooling. So, you know, be sure if you're prescribing these, which I don't hope, hopefully these are all only being prescribed by psychiatric mental health specialists, that you're telling people that their kid might drool. It's in 29 to 35% of kids on Risperdal that are of autism have drooling. So how's that for going to school, right? We're going to give you this medication so you do better with your behavior, but by the way, you might drool. So be sure to tell people that, because we need to be informed, right? Weight gain. Weight gain is significant. And I'm not able to see all my notes here. The weight gain that we see is in many kilograms. We're seeing kids gaining 20 pounds. All of them have weight gain, so the least is about 7 or 8 pounds. But definitely they all have weight gain. They have metabolic and lab changes, and I'm going to come back to that in just a second. All these kids are at risk, increased risk for neuroleptic malignant syndrome. And the thing with the antipsychotics is that can occur at any point. They could be on it for a long time and just out of the blue have it. And we don't know why. And so that is a little bit concerning with all of the antipsychotics. And then we have a couple that we have to worry about prolonged QT. So we do have to pay attention to the adverse effects. The most adverse effects are on the very young kids. So the younger they are, the more problems they're going to have. And as they get older, it's less of a problem. Okay, so metabolic changes. This is where in primary care we need to pay attention, because they're going to come to see you for a checkup, and you need to make sure they're getting their labs done. And so all kids need to be monitored for elevations in fasting insulin. They can develop insulin resistance, so you want to do their A1Cs. You could take a perfectly healthy kid and put them on a drug like this and make them a diabetic, okay? And it does happen. So these kids have to be monitored and monitored frequently. You don't just do their one time you do A1C. We need to watch them carefully. They have decreased HDL levels, which is not the direction they want to go, okay? Elevated prolactin levels, so we see things like they get breasts sometimes, and elevated liver enzymes. So we got to make sure that we are monitoring these metabolic changes in these drugs. So if they're seeing our own psychiatrists within Kaiser, they just order the labs the next time, and we're drawing them. So we just need to make sure when they come for their primary care visit, did you go get your labs drawn? If they're outside of Kaiser, we need to order them for them and make sure they're getting their labs drawn, okay? So you need to figure out with your system, even if you're not prescribing, you need to make sure that we're being, because guess who they come to for their lipids and their diabetes? They're not going back to the psychiatrists. They're coming to us. So we need to pay attention to this and catch them early. So neuroleptic malignant syndrome, if you've been out of nursing school for a while. So this is a really interesting thing. It doesn't happen very often, but it does happen. They show up with altered mental status, high fevers, diaphoresis. They have 100% have elevated creatinine phosphokinase. And if they show up, we need to really be on top of them and do aggressive treatment and get them cooled down and get their electrolytes under balance and muscle relaxants, or it can be fatal. So be sure to talk to people about this and ask them, just say, if you have any of these symptoms that need to be seen right away. Do you have your hand up?
How often do you do the lab?
Well, we see our adolescents every year. And just for well checks, we just make sure that they get them done. Yeah. There might be more frequent monitoring by the psychiatrist, but in primary care, we just make sure that they're getting them when we see them for their well checks. I don't know if there's actually a recommendation about how often. I haven't seen an exact date, like every 6 months or something. I haven't seen that. Has anybody seen that? Yeah?
I worked with the developmental behavioralists, and we do every 3 to 6 months.
Every 3 to 6 months? And those are the younger kids, though, right? The younger kids you're monitoring more frequently than the older kids. So every 3 to 6 months is what they're doing with the younger kids in developmental peds. Okay, so this is just a risk, just not to keep it tucked away. Everybody who's on an antipsychotic, whether it's atypical or atypical, is at risk for this. So they go off to the psychiatrist or the advanced nurse practitioner that is appropriately prescribing. That's who should be prescribing these. I don't think that unless you have specialty care managements that you should be prescribing these atypicals in primary care. That's my personal opinion, but it also, I think, is what is best practice. But we still need to, in primary care, sort of watch them, sort of find out how they're doing on their meds. Are they going to see their, getting their mental health therapy? Are they seeing their psychiatrist? Are they following through? Are they taking their meds? What I see is a lot of them are sporadic takers. They take it for a while, and then they gone, and then you see them, and they haven't been taking it, but they don't, you know, it's like, are you seeing that? They're kind of, it's really an interesting dynamic sometimes with these kids. And so trying to collaborate with the mental health provider about prescribing these. Sleep disorders. Now this is all in primary care, right? How many of you have seen a kid with sleep problems? Right? It starts in infancy. Actually, it's the parents that can't sleep then. And then it goes through. So I always get this of like, what do I do for my kid who won't go to sleep? All right? And there's not good evidence on what medications to use in kids. We know that in the okay, I know you guys aren't doing over there. There's something going on in the next room, some tape or something, you know? Okay, in the general population, 1 to 3% of kids have sleep disorders. Now, I don't know, maybe my practice is weird, but I think it seems like more than that, you know? Our problem is the kids have all these, they have TVs in their rooms, they're sleeping with their cell phones, you know, we've got, is that a sleep disorder? Or is that an electronics disorder? And get that stuff out of the room and they'd sleep fine. Okay, so that's the first thing we need to look at before we call it a sleep disorder. If we look at kids with psychiatric and neurodevelopmental disorders, 50 to 75% of those kids have sleep problems. Okay, so they are a specialized group. Melatonin. The problem with melatonin is it's not well studied in kids. So one of the issues with drug studies is someone has to fund it, right? And there's not money to be made from melatonin, right? Because melatonin has already, it's out there as you can go down to Safeway and buy it. So why would you do a study, right? So in the studies that we looked at kids with neurodevelopmental and psychiatric disorders, generally the dosing that they're recommending is 1 to 3 milligrams, 30 to 60 minutes before bed. It shouldn't be used every day. It's pretty clear it's a hormone, okay? It can cause some adverse effects from hormonal changes. If they're taking it, it should only be a couple nights a week at the most. And so we really need to pay attention, because if we're recommending it, we need to be really clear this isn't an everyday thing. You need to work on your sleep hygiene. You need to exercise. You need to get to bed and have a routine, etc. Now, where there is money to be made is the melatonin agonist, which basically they said, oh, melatonin receptors, let's make a drug that does that we can charge a lot of money for. So this is Rosarim. And it binds to the melatonin receptor just like melatonin does, but it's not approved in children and adolescents. So of course it says on the label not to use it in kids. For kids, the antihistamines, so it's really loud next door all of a sudden. You can use over-the-counter diphenhydramine. Just be careful. The parents will go, oh, can I give them Benadryl? I'm like, well, you know, I'd prefer not even if you have to. One of the issues is kids can have a paradoxical reaction, and so that means instead of making them sedated, it can make them hyper. So I don't recommend at all this for sleep. But the problem is if you go to the store and you look at sleep medicines that are like Unisom and some of those other ones, a lot of them are diphenhydramine with Tylenol or just diphenhydramine with a different label than Benadryl. So I do talk about paradoxical reaction. People ask me, oh, can I give them Benadryl? We're going on a long trip on the plane. So can I give my kid Benadryl so that they're do well? I said, well, it probably won't hurt them, but you might want to test it at home, because if they're the one that's going to have a paradoxical reaction, you don't want to be on a plane with a kid that's hyper. And so, because, people, they have all these, their friends say, oh, I just give my kid Benadryl before we travel, and it just works fine. Well, every kid's not the same, and they don't come with a little label that say, I'm the one that's going to react like that. So I'm not a real fan of using sleep medicines in kids, but that's probably won't hurt them. The benzodiazepine-like drugs, which is our Zolpidem and those, they're not approved for use in kids. They have studied these for kids. They looked at them for insomnia associated with ADHD. They did a trial of 6-year-old to 17-year-olds. And what they found is that they end up with a lot more of these psychiatric and nervous system disorder things. They had 23% of them had dizziness, they had headaches, they had hallucinations. Old people don't tolerate these either. I always say kids and old people, if anybody's going to respond to these things weirdly, it's going to be kids and old people. So they said, oh, this is not a good idea. These are not to be used in kids because they just have a lot more problems with them. So it has been studied. They say not to use them. That's why the label says that. Not that they haven't studied it. Okay? So that's what's with that. A little bit about pharmacogenomics, because this is another area where we're learning more and more about these drugs. We already talked about methylphenidate and dopamine receptors. So the stimulants work by increasing the number of neurotransmitters in that synapse. Dopamine is one of them. And there may be something going on with those receptors so they don't respond to methylphenidate. We've already talked about amoxicillin. One of the things we see with the SSRIs is we know genetically, like Asians have a more exaggerated response to some of the antidepressants or less response. We know that people that are 2D6, either poor or rapid metabolizers, won't respond to some of the antidepressants. Either they won't respond or they'll have more adverse effects. So if they're a poor metabolizer, they may not have a response. If they're a rapid metabolizer, they may have an exaggerated adverse effect profile. So be sure to think about that, look at that before you prescribe them, because if the patient is describing to you something that's either they're having too much of a response or not enough of a response, you got to take it back. Remember that genetics we talked about? There's a genetic link with these things. Well, there's pharmacogenetics with these, so we got to pay attention. It could be genetically they're not responding. So if we look at the drugs that use 2D6, we have our fluoxetine, okay, paroxetine, 2C19, amitriptyline, some of the others. So when we look at our primary enzyme that's used for metabolism, you need to, if someone has genetically, that enzyme either is not working well or they're an ultra metabolizer, they're not going to have the same adverse effect profile as someone who doesn't have a genetic alteration. And we're learning, as we learn more, we have more data. So until we have a genetic test that you can go in and say, okay, you need to go find out if you're a 2D6 ultra metabolizer. All right? We're going to do a test on you. And actually, you can test for some of these. We don't know all that. What you will see in clinic is they either respond or they either don't respond or they have more side effects than predicted. There are some FDA-approved tests for some of these, but they're so expensive. It's sort of like, until the test costs come down. But this is an area that a lot of studies are happening to figure out how to get the tests so these are cheaper. When do you think about pharmacogenetic testing? When they're not responding, and you absolutely must have compliance. Especially if they've failed on 2 different medications, you can test for some of these isoenzyme genetic variations. There are some FDA-approved tests. So if you keep trying and they're just not responding to the antidepressant, you need to sort of sort all that out. And one of the pieces of things you need to sort out is do you want to do genetic testing or not? Or if they're having really bad side effects and you're reading the literature and it says, oh, this isn't even supposed to be happening with this drug. Why is this happening? Well, it's possible that it's genetically, they're ultra metabolizers that are having an exaggerated response. Who knows sometimes? We don't have it all sorted out. But it's sort of like the whole genetic piece. The more we learn, the more we don't know. But we are moving, and I sat next to somebody on a plane one day, and he works for some company, and that's all their research. They're figuring out how to make low-cost genetic testing, and they're looking at SNPs and this and that, and I was just like, my head was spinning. But there's money to be made if they can figure out how we can test some of these people ahead of time, easier and cheaper, because there will be money to be made, and that's why they're really looking at this. Okay. So antidepressants can be safely prescribed. You need to monitor them. You need to combine it with cognitive behavioral therapy. Antipsychotics, be sure that an expert clinician is diagnosing them and watching them for ADRs. And always think pharmacogenetics if you're not getting the expected response.